Welcome to Rheumatology Virtual Grand Rounds. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology here at the Cleveland Clinic, bringing to you another outstanding case in our series. Today is really a special treat for me. Philip Mease is the Director of Rheumatology Research at the Swedish Medical Center and Clinical Professor of Medicine at the University of Washington School of Medicine. I think any rheumatologist listening in knows Dr. Mease's wide-ranging expertise. I think perhaps his most foremost area is this emerging and rapidly proliferating area of psoriatic arthritis, pathogenesis, classification, and disease management, and of course related to spondyloarthropathies. So I've asked Phil to put together a challenging case for us today and try to bring out some best practices for all of us. So Philip, welcome.
Hello, my name is Philip Mease. I'm a clinical rheumatologist from Seattle, Washington. I'm the Director of Rheumatology Research at the Swedish Medical Center and Clinical Professor at the University of Washington School of Medicine. Today I'd like to review a complex case of psoriatic arthritis. A 42-year-old white female referred for evaluation of persistent foot pain by a foot and ankle orthopedic surgeon. Her pain has been present off and on for 8 months, but in the last 3 months it has become continuous and worse, thus prompting this referral. 8 months ago, she developed a flare of pain in her left forefoot. Her primary care physician thought it was gout because it was isolated to the forefoot, and her uric acid level was 8.2. She was given colchicine 0.6 milligrams twice a day and naproxen 500 milligrams twice a day. The pain resolved over a week. She developed diarrhea, however, thought to be related to the colchicine. A month after this episode, she had a recurrent flare of pain in the forefoot, and this time also in the left heel, both impairing her ability to walk. Uric acid level was 7.6. This time, just naproxen was employed to treat the pain presumed due to gout, since colchicine had caused diarrhea previously. Because the uric acid was elevated and because this was her second episode, her PCP advised her to begin allopurinol 100 milligrams per day once the pain resolved, which occurred in the forefoot in about a week. When she was seen after a month, heel pain was persisting, so she was referred to a podiatrist. Uric acid level was 6.6, so the PCP had her increase allopurinol to 300 milligrams per day. The podiatrist noted a normal X-ray and fashioned orthotics for her, including a heel lift, which ameliorated but did not fully resolve her heel pain. In 2 months, she experienced recurrent pain now of both forefeet as well as persistence of left heel pain, which significantly impacted function. Uric acid level was now 5.2. Stumped, realizing this might not be gout, the PCP referred her to a foot and ankle orthopedic surgeon. The surgeon noted normal X-rays, diagnosed mechanical Achilles tendonitis and metatarsalgia, suggested that she switch from naproxen to meloxicam 7.5 milligrams twice a day and continue to use the orthotics. After 3 weeks without improvement, he referred her on to a rheumatologist. The initial history by the rheumatologist yielded a number of points. She had pain in her feet and heel, as noted previously. She's had recent pain in her hands. She also notes pain in her lower back, which she considered age-related. Morning stiffness lasted about 40 minutes in the hands, back, and feet. She had noticeable fatigue, not characteristic for her, as well as sleep disturbance. Chest pain was present, which had troubled her about why it was there. A flaky scalp rash for which she has been using a tar shampoo and which she attributed to just bad dandruff. She has a negative family history for autoimmune rheumatic disease, psoriasis, or inflammatory bowel disease. On physical exam, her weight was 185 pounds, slightly overweight. Her height was 5'6", and her blood pressure 145/90. The skin exam revealed a scaly erythematous rash at the scalp line behind the ears and in the occiput above the collar. Her nail exam showed subtle pitting. Musculoskeletal exam revealed the following in the peripheral joints: tenderness of the right second and fourth distal interphalangeal joints, the second and fourth metacarpophalangeal joints, the left third DIP, and the fourth MCP, also tender. Both sternoclavicular joints were tender, and on examination of her feet, the right second and third MTPs and the left second through fifth MTPs were tender but not swollen. The remainder of her exam of the peripheral joints was unremarkable. Examination of her spine revealed pain with palpation of the lower back and upper buttocks. When we moved to doing the enthesitis-specific exam, it was noted that she had pain with palpation over the left inferior patella and at the left Achilles tendon insertion. There was no evidence of dactylitis. Initial laboratory and X-ray showed an elevated CRP of 2.6 with normal up to 0.8. Her SED rate was 22, uric acid normal at 5.1, rheumatoid factors slightly elevated at 48, CCP negative, ANA negative. Her liver function test showed very mild elevation with an SGOT of 58 and an SGPT of 56. Note that these elevations were not apparently related to a medication, and since she was mildly overweight, could have been related to fatty liver. X-ray of the pelvis showed normal SI joints and hips. X-ray of the lumbar spine showed minimal DJD changes. X-ray of the hands were normal. Review of X-ray of the feet and ankles also normal. Ultrasound of her left Achilles tendon showed positive power Doppler signal and slight thickening of the tendon. Ultrasound of the left patella was normal, and ultrasound of select MTPs and MCPs was also normal. Given this background, what is your initial idea about diagnosis? Do you think this represents rheumatoid arthritis, polyarticular gout, psoriatic arthritis, reactive arthritis, or osteoarthritis? Psoriatic arthritis is the correct answer, as the patient has several features typical for PSA, including multiple joints that are tender, scattered in a somewhat asymmetric pattern about the hands, feet, and the sternoclavicular joints, enthesitis of the left patella and heel, with inflammation suggested by positive Doppler signal on ultrasound, the possibility of inflammatory spondylitis, which has yet to be further worked up, in the context of what appear to be psoriatic lesions at the scalp line, as well as nail pitting. It's certainly understandable why the PCP initially thought about gout, because of the fact that she had what appeared to be isolated pain in her left forefoot, as well as an elevated uric acid, which, by the way, is not uncommonly elevated in patients with psoriasis. However, as the clinical story evolved and she had more places that were tender, then it became more apparent that she had a systemic inflammatory disease such as PSA. Rheumatoid arthritis could be considered including the notation of a positive rheumatoid factor, but the constellation of symptoms and signs consistent with PSA leads us to prefer the PSA diagnosis. Polyarticular gout is now unlikely given the fact that the patient has a uric acid level less than 6 on allopurinol, yet is worsening. Reactive arthritis, i.e. an arthritis of the spondyloarthritis variety that follows exposure to an infectious agent such as Salmonella, Shigella, Yersinia, Campylobacter, or Chlamydia, could also be a consideration. But in the absence of clear-cut history of such infection, this seems less likely in the face of signs more consistent with PSA. Also, osteoarthritis could be a consideration given arthritis symptoms in several DIP joints and minor degenerative changes noted in the lumbar spine. However, the overall distribution of joint involvement, including the MTPs, which are not typically involved in OA, as well as features such as AM stiffness, fatigue, and elevated acute phase reactants, makes OA unlikely as a unifying diagnosis. Which of the following statements about classification criteria is correct? The patient fulfills ACR-EULAR 2010 classification criteria because she has more than 6 weeks of disease, convincing inflammatory disease of the small joints of the hands and feet, a positive rheumatoid factor, and elevated acute phase reactants. The patient fulfills CASPAR classification criteria for PSA because she has inflammatory arthritis, enthesitis, and spondylitis, psoriasis, and nail changes. 3. The patient cannot fulfill CASPAR classification criteria for PSA because her rheumatoid factor is positive. The correct answer is the CASPAR criteria for the classification of PSA. The CASPAR criteria for the classification of PSA, published in 2006, reflects a study of over 1,000 subjects, half PSA and half another form of inflammatory arthritis, evaluated in 31 centers across the world. If a patient has, in the opinion of the clinician, an inflammatory form of arthritis, enthesitis, or spondylitis, and 3 points from a list of additional elements, then they can be categorized as a patient with PSA according to this criteria, which is the correct answer. Current psoriasis garners 2 points. If a patient does not have current psoriasis, but does have a history of psoriasis or a family history of psoriasis, then that constitutes 1 point. Additional elements include being rheumatoid factor negative, having nail changes consistent with psoriasis, having dactylitis, or having evidence of periarticular osteitis. In this instance, the patient has clear-cut evidence of inflammatory arthritis and enthesitis, and possibly spondylitis, as well as current psoriasis and nail changes. This gives her 2 points for current psoriasis and 1 point for nail changes, in addition to inflammatory joint, enthesial, and possibly spine disease. She has a positive rheumatoid factor, but it should be noted that even in patients with clear-cut PSA in the CASPAR study, about 5% had a positive rheumatoid factor, so this is not exclusionary. The criteria had a specificity of 99% and sensitivity of 93%. High specificity is a desirable feature for classification criteria, which are intended to accurately classify patients for inclusion into research studies. Although on face value, the patient seems to fulfill the ACR-EULAR 2010 criteria for rheumatoid arthritis by having polyarticular involvement, chronic duration of symptoms, a positive rheumatoid factor, and elevated acute phase reactants. However, when the criteria are applied, one is supposed to exclude patients who appear to represent another inflammatory arthritis condition, such as PSA, lupus, etc. In this case, the patient displays multiple features of PSA, such as presence of psoriasis, enthesitis, and spondylitis, so would theoretically be excluded from having the RA criteria apply. Also, although she has multiple tender joints, none are definitively swollen, which is supposed to be a requirement for joint involvement in the RA criteria. Now we go to the second visit with the rheumatologist. The patient is returned after a week to discuss laboratory and X-ray findings. The rheumatologist explains why he thinks PSA is the correct diagnosis, the difference between PSA and other arthritis conditions in the differential diagnosis, including RA, some understandable description about the mechanisms of the disease, and potential natural history courses. He emphasizes the need for effective treatment in order to optimize clinical well-being, function, and to try to prevent down-the-road damage. He discusses a variety of treatment options in addition to nonsteroidals, including methotrexate, leflunomide, sulfasalazine, and anti-TNFs. Further workup recommended includes MRI scanning of the lumbar spine and pelvis to assess whether bone edema is present and indicative of inflammation seen in spondylitis. In this patient, bone edema was ultimately noted in the left sacroiliac joint, as well as L4 and 5, suggesting the presence of an inflammatory spondylitis as a component of her psoriatic arthritis. The rheumatologist spends some time in the second visit counseling about PSA comorbidities, including elements that constitute the metabolic syndrome, such as obesity, hypertension, and hyperlipidemia. He describes some preliminary research that suggests that weight loss can lead to better treatment outcomes and that control of weight and blood pressure are important aspects of improvement of cardiovascular health. He asks about what the patient knows about her cholesterol levels, which are being monitored by the PCP. She thinks they are normal, but will double-check. She also has been thinking about purchasing a blood pressure device for home monitoring and promises that she is trying hard to control her weight. Noting the slightly elevated LFTs, the rheumatologist describes that some patients with PSA and obesity may have fatty liver, which can be a reason for slightly elevated transaminases. He notes this is something they will need to monitor if they use a medicine that can have adverse hepatic effects, such as methotrexate or leflunomide. Now we come to our third question. Which is the correct agent to choose in addition to the patient's current NSAID therapy? Methotrexate, leflunomide, sulfasalazine, anti-TNFs, or any of the above? Any of the above is the correct answer to this question, although the evidence base for effectiveness of the oral DMARDs is not as robust as we would ideally like. The best evidence base for effectiveness of therapy across all clinical domains of PSA, arthritis, enthesitis, dactylitis, spondylitis, and psoriasis, as well as function, fatigue, and quality of life, has been shown with the various anti-TNFs which have been approved for PSA, etanercept, infliximab, adalimumab, and golimumab. However, because of their cost, many insurance companies, as well as state and federal government programs, require the clinician to try a less expensive oral DMARD prior to allowing approval of an anti-TNF. Thus, typically we will first try such an oral agent. Methotrexate has been a workhorse for treatment of inflammatory arthritis conditions over the decades, and all of us have PSA patients whose arthritis and psoriasis has responded to methotrexate. However, effectiveness has not been clearly demonstrated in randomized placebo-controlled clinical trials. There have been two such trials, one conducted by Bob Wilkins et al. In 1984, and the other by Kingsbury et al., published in 2012, known as the Methotrexate in Psoriatic Arthritis, or MIPA trial. Neither trial was able to demonstrate significant discrimination between methotrexate and placebo in key measures. Yet both trials had significant problems. The Wilkins trial recruited an insufficient number of patients to do an adequate assessment, as well as having one group of patients taking an insufficient dose of methotrexate of just 7.5 milligrams per week. The MIPA trial was handicapped by a number of factors, including high patient dropout and the possibility of channeling bias, i.e. having the investigators channel their less severe patients into the trial, as well as possibly insufficient dosing of methotrexate. Thus, we are still in need of an adequately enrolled study of methotrexate to truly assess if methotrexate can be demonstrated to be effective in controlled trials. Further issues with methotrexate are that it has not been formally studied to see if it can have an impact on structural damage as measured by radiographic progression. It does not appear to beneficially affect spine symptoms in studies in a related condition, ankylosing spondylitis. The Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, or GRAPPA, in its International Treatment Recommendations for PSA, has recommended extrapolating from ankylosing spondylitis data to evaluate the effect of methotrexate in inflammatory spine disease of PSA. Liver function tests must be carefully monitored, especially in someone with already raised LFTs from fatty liver. Leflunomide has been studied in a randomized clinical trial in PSA. It demonstrated statistically significant benefit for the arthritis component as well as the psoriasis component, although not as robustly for the skin. Enthesitis and dactylitis response were not assessed. Leflunomide has not been effective in spine symptoms in AS trials. Liver function tests need to be monitored, similar to the recommendations for methotrexate. Sulfasalazine has been studied in PSA and showed modest benefit for arthritis aspects, but not for skin. Enthesitis and dactylitis were not assessed. Sulfasalazine has not been effective in the spine in AS trials. Methotrexate was chosen for this particular patient, and after 3 months on methotrexate therapy, the patient has improved pain in her hands and feet, about 30%, she states, but has had no improvement of her back or left heel pain. The latter continues to be her most disabling feature, since in her job she has to walk a fair amount. Further, she describes some degree of nausea on the day she takes methotrexate, so has decided that Sunday is the best day of the week to take it, since it interferes least with work and home activities that day. Fatigue has improved about 10%. We've maximized dose to about 20 milligrams, so there's not a lot of room. Maybe some would go up to 25 milligrams per week. Exam reveals no change in her tender or swollen joint count, left patella or Achilles tendon insertion pain, or back pain. Laboratory shows CRP has improved to 1.2, SED rate to 15. There is no change in mild elevation of SGOT and SGPT, so it doesn't appear that methotrexate is negatively impacting her transaminase levels. So at this juncture, we're wondering, what should we do? Should we increase methotrexate to 25 milligrams? Should we switch over to subcutaneous methotrexate? Should we switch to a different medicine, or should we add another medicine? The patient's rheumatologist adheres to the value of treating to target in rheumatic diseases based on the evidence for its value in RA treatment. Judging that she has experienced minimal improvement from methotrexate therapy, he recommends that she initiate anti-TNF therapy in order to have optimal opportunity to achieve low disease activity state in several clinical domains, including spondylitis, enthesitis, and skin disease, in addition to arthritis. Our next question is, a target for achievement of minimal disease activity has been developed for psoriatic arthritis. True or false? The answer is false. Minimal disease activity criteria have been developed for PSA by the GRAPPA group. The development of these were based on an evaluation of numerous case studies by GRAPPA members. To achieve an MD state, 5 of 7 following elements must be met: swollen joint count less than or equal to 1, tender joint count less than or equal to 1, PASI score, which is a composite skin assessment, less than or equal to 1, or, more easily done, an assessment of body surface area less than or equal to 3%. Patient pain, VAS, less than or equal to 15 out of 100. Patient global VAS, in all of the ways their disease affects them, less than or equal to 20 out of 100 points. HAQ score less than or equal to 0.5, and an enthesitis count of less than or equal to 1. This measure has been evaluated in a large clinical registry of PSA patients and retrospectively in a phase 3 clinical trial of an anti-TNF medicine. It is being used prospectively as a response measure in several emerging trials in PSA. We are able to use this criteria in clinic. It's fairly easy to do. Obviously, rheumatologists are comfortable with doing tender and swollen joint counts. You can use whatever enthesial count you desire to do. What I often do is use one of the simple ones, such as the Leeds enthesitis index, which involves evaluation of the lateral epicondyle at the elbow, the femoral condyle, and the Achilles tendon insertion. Many individuals are used to assessing the Achilles tendon, possibly the plantar fascia, and the patella. Body surface area of skin psoriasis can be assessed by the handprint mechanism, in which a handprint, if you were to, say, dip your hand in some paint and put it on a piece of paper and then calculate the surface area of that, that would be approximately 1% of your body surface area. So if you do a guesstimate of the lesions on a patient's body, and they are using this methodology, you can come up with understanding whether or not the patient is less than 3% or more than 3%. In this case, the patient just had a mild degree of psoriasis involvement around her scalp line, and so it clearly is less than or equal to 3%. However, we do note that we will come to note that the patient has not yet achieved this degree of improvement with methotrexate alone. There are several emerging trials that are evaluating the value of treatment to target in PSA, including the TICOPA trial that employ quantitative targets of treatment such as the GRAPPA MDA criteria. The GRAPPA group has also developed new composite measures of disease severity and response, ratified by the Outcome Measures in Rheumatology Clinical Trials, or OMERAC group, to be used in emerging clinical trials to assess their reliability, responsiveness, and discriminative ability. These composite measures, known as the CP-DI, the PASDAS, and the AMDF, take into account the heterogeneous clinical domains of PSA, arthritis, enthesitis, dactylitis, spondylitis, and psoriasis, and do not just focus on arthritis improvement, as do the ACR response criteria and DAS measures of disease activity and response. Exploratory thresholds demarcating remission, low, moderate, and high levels of disease activity are being created for these composite measures. It is anticipated that one of these will become standard for use in clinical trials and potentially clinical practice, as historically measures such as the DAS28, SDI, and CDI have in rheumatoid arthritis. Back to our patient, because she has not fulfilled MDA criteria using methotrexate, because she still has a significantly elevated tender and swollen joint count, for example, as well as enthesitis, pain, and so on. The patient is started on an anti-TNF agent in addition to methotrexate after appropriate counseling regarding risk, including the risk for serious infection, and checking to see that her quantiferon gold assay, hepatitis serologies are negative, and chest x-ray is normal. After 3 months, her tender joint count is 4, swollen joint count 0, body surface area less than or equal to 1%, HAC score 0.5, patient pain VAS 10, as is the patient global VAS. And there is no tenderness now with palpation of the left patella and Achilles tendon insertion. So she now has achieved MDA criteria. You discussed the plan to try tapering off methotrexate, partly because of the experience of once-a-week nausea, but also the mildly elevated liver function test, which had been attributed to fatty liver. Follow-up visit is planned to quantitatively assess disease severity as methotrexate is gradually discontinued to determine if this is the correct decision or should be restarted if disease activity increases in the future. She then continues on anti-TNF therapy, having achieved a significant improvement in a number of manifestations of disease in distinct clinical domains, such as joint disease, enthesitis. She's now experiencing less back pain, as well as improvement of her psoriasis. This all leads to improvement in function and quality of life, and thus a positive outcome. Thanks very much for walking through this somewhat complex case today that started off in a either monoarticular or oligoarticular manner, confused with gout, and then evolved into involving a number of different clinical domains that are consistent with psoriatic arthritis and have ultimately responded to anti-TNF therapy. Thank you very much.
Thanks, Phil. That was outstanding. I think you really brought out several points. First of all, the diagnosis of psoriatic arthritis is not always straightforward. Rheumatologists have long known that this can be subtle and the disease can antedate skin diseases. Secondly, the spectrum, as defined by the CASPAR criteria, clearly indicate that calling it arthritis is probably incorrect, where we have dactylitis, enthesitis, spondylitis, and arthritis. So I think it's a useful model for approaching the disease. Thirdly, I think you've gone through the therapeutic options very nicely, and it doesn't take a whole lot to see that TNF inhibition is central in the management of this complex disorder, being the only drug that has significant efficacy in all the domains of inflammatory musculoskeletal disease. The last issue I'm still not satisfied with. While treat to target and rheumatoid is now an increasingly endorsed and readily available and achievable goal, at least to measure it, the minimal disease activity right now, which is really a tool for clinical trials, is pretty cumbersome and not intuitively obvious. But still, taking a good physical exam with tender and swollen joints, patient-reported outcomes, and then looking at other sites such as entheses will give us a good high-altitude view of our control. So thank you again, and I'd like to tell everybody to come back to virtual grand rounds. We have a lot of other great cases on the web.